The other side of the debate, we are glad to introduce Professor Mahmoud Salah, الأستاذ الدكتور محمود صلاح.
Bismillah ar-Rahman ar-Rahim. First, I would like to thank my dear friends here in the organizing committee for inviting me here. I'm always honored to be here. And today I'm honored to debate with my friend Dr. Hisham. I'm going to talk about infrapopliteal angioplasty. The more, the better. What are the challenges we are talking about in the BTK? We all know that we are talking about small caliber vessels, long lesions, high calcium burden, low flow, elastic recoil, dissection, restenosis, all these challenges we all know. And the angiosomes, which was explained very well by Dr. Hisham, about these 6 angiosomes, 2 from each vessel, so I'm not going to waste again your time. But talking about single or complete revascularization. Actually, there was no difference seen between single vessel versus multi-vessel in terms of major amputation and amputation-free survival. So I completely agree with my friend Hisham about this point. But the retrospective review of 250 limbs had infrapopliteal angioplasty over 8 years found that combined multi-vessel reperfusion resulted in significant improvement over simple indirect reperfusion in amputation survival and reintervention and wound healing. So also a systematic review and meta-analysis was done in 2021, and they showed that direct reperfusion resulted in significantly improved wound and limb salvage than indirect reperfusion, but had no effect on the reintervention rate or the mortality rate. Also, significant difference was found for wound healing rate in direct revascularization was about 91% versus indirect was 62%. These are the pillars of successful below-knee angioplasty. It does not depend only on the experience of the operator, but also on the availability of devices and the type of lesion and the access. The pre-planning is very important. Careful examination of the foot lesion and defining which angiosome we are going to attack, which is the most important vessel we need to revascularize. This is very important to know. CT angio may be not sufficient in all cases, and selective popliteal or tibio-peroneal angiography is very important. These are some cases. This is total occlusion of the popliteal artery and infrapopliteal vessel. The only vessel available is the anterior tibial. We managed to revascularize the anterior tibial, and then, the posterior tibial, and this is the anterior tibial revascularized, and then this is the peroneal. So our strategy is always to go through to complete revascularization. The single vessel is if we could not reach this point. So if we failed for complete revascularization, we can have single vessel. But usually we are aiming at complete revascularization. This is gangrene of the big toe, and this is the patient having very good posterior tibial and peroneal, but no anterior tibial vessel. You can see that the posterior tibial is even reaching to the foot, but still he have this gangrene of the big toe. This is after revascularization of the anterior tibial, and you can see complete arch. This is a patient who had amputation of the big toe, but as you see, he had gangrenous stump. This patient had very good posterior tibial pulse, and depending on this, somebody did amputation of the big toe for him, but it was not successful, as you see. So we found that this, you can see very good posterior tibial, no anterior tibial at all. This is the posterior tibial reaching to the foot. We tried hardly to revascularize the anterior tibial. Actually, we could not reach the dorsalis pedis at all. But strange enough that through the peroneal artery, we could reach the dorsalis pedis, and you can see that the balloon is coming from the medial side to the dorsalis pedis. And this is, you can see that the anterior tibial is not revascularized, but the peroneal is revascularized and reach it to the dorsalis pedis. And this is, you can see, after we did debridement of the big toe. Another case of big toe gangrene, again, as you see, good posterior tibial, no anterior tibial, and after revascularization of the anterior tibial, this is, you can see the posterior tibial reaching to the foot, no anterior tibial. This is after revascularization, and this is the arch. Again, amputated big toe, as you see, no anterior tibial. Also, the posterior tibial and peroneal were very good, and this is after revascularization of the anterior tibial and the arch. This is ballooning of the anterior tibial, dorsalis pedis, and the arch, and this is the net result. This is a patient having a problem in the posterior tibial. This is not retrograde axis. This is actually where the wire stopped. So this is just breaking of the calcium for this area, because the wire and the balloon were not crossing at all. So this is after we crossed, and as you see, we are ballooning the puncture site of the posterior tibial, and you can see that the balloon even reached to the arch. This is a tough popliteal occlusion. We could not go antegrade, having very good pedal vessels, and this is antegrade, and this is we could manage to reach up and snare the wire from above, and this is after revascularization. Again, this is a case pre and post operative. In conclusion, the site of the lesion is the key factor for success of the angiosomal concept in management of critical lower limb ischemia. Revascularization of the source artery to the angiosome result in better wound healing and limb salvage rate in comparison to the single vessel. Direct revascularization of the arteries supplying the target angiosome or the wound area, resulting in less complication, and no further debridement is needed in comparison to the patient where angiosome therapy could not be applied. And finally, what I would like to say to my friend Hisham, that God created 3 vessels in the leg for a reason. Thank you very much.
Thank you, Professor Mahmoud, for your nice presentation. Actually, we are a bit late, but we still have some time to ask questions.